Assalamualaikum warahmatullahi wabarakatuh, and hi, I bid to Miss Vida. Welcome to my presentation video. I'm Balki Zulaika binti Edi Roskam from HS262 Part 2 Group A. In this video, the subject or the projection that we are going to look for is lateral projection of thoracic. The contents that I'm going to present in this video are anatomical structures visualized in lateral thoracic projection, the criteria for lateral thoracic positioning, the criteria for lateral thoracic exposure factor, the PACEMAN method for lateral thoracic image evaluation, and the last one, we are going to look for the radiograph acceptability after the PACEMAN method that has been applied to evaluate the image. So we are going to move to the first content, which is the anatomical structures that should be visualized in lateral thoracic projection. So these are the anatomical structures that can be visualized in lateral thoracic projection. The first structure is posterior ribs, followed by intervertebral foramen, intervertebral disc spaces, which are located in between vertebral bodies, pedicles, and the most important one is thoracic spine from the first thoracic until the 12th, and all these anatomical structures are very important in evaluating the radiograph later. Next, we are going to move on to the next content, which is the criteria for lateral thoracic positioning. In the slide, it is stated that the positioning criteria for lateral thoracic are intervertebral foramen are visualized, the pedicles are seen in the profile, the posterior surfaces of each vertebral body are superimposed, and the left and the right side of the posterior ribs are separated not more than 1.25 cm or half inch, and then intervertebral disc spaces are open, and the last one is T7 is at the center of the collimated field, and it includes from the C7 or 7 cervical to the first lumbar. For this projection, rotation can happen for lateral thoracic projection, but the rotation may occur independently or simultaneously. For example, if the shoulders were not placed on top of each other, but the axes were aligned, the upper thoracic vertebrae demonstrate rotation, and the lower thoracic vertebrae demonstrate lateral projection. But if the axes were rotated, but the shoulders were placed on top of each other, the lower thoracic vertebrae demonstrate rotation, while the upper vertebrae demonstrate a lateral projection. Hence, in order to determine whether the patients were rotated or not, there are two things that we may look at or evaluate from the radiograph. The first one is the superimposition of the right and left posterior surfaces of the vertebral bodies, and we may also evaluate the amount of posterior rib superimposition. As for the superimposition of the right and left posterior surfaces of the vertebral bodies, on a non-rotated lateral projection, the posterior surfaces of vertebral bodies are superimposed to each other. However, on a rotated lateral projection, the right and left posterior surfaces of vertebral bodies are demonstrated one anterior to another. Next, rotation can also be determined by assessing the amount of the posterior rib superimposition. On a non-rotated lateral projection, the posterior ribs are almost superimposed. Meanwhile, on a rotated lateral projection, the posterior ribs demonstrate more than 1.25 cm or more than half inch, indicating that the patient's elevated side was rotated posteriorly. These are some of the examples of incorrect positioning of patients. The first diagram shows that the right side of the patient's body was rotated anteriorly. Hence, to improve this, the right side of the patient's body must be rotated posteriorly until the MCP or mid-coronal plane is perpendicular with the IR or image receptor. The second diagram shows that the right side of the body was rotated posteriorly, and to improve this, The right side of the body must be rotated anteriorly until the MCP is perpendicular with the image receptor. The next diagram shows that the projection was taken with the patient's lower thoracic vertebrae positioned closer to the IR than the upper thoracic vertebrae. Moving on to the next content of this presentation, which is the criteria for lateral thoracic exposure factor. The visualization of BCO or bony cortical outline will be used to determine whether the KVP used is adequate for penetration. However, the visualization of BTP or bony trabecular pattern is used to determine whether the MAS used is adequate for density and details. Hence, for lateral thoracic projection, for thin structure, we are going to evaluate both the visualization of BCO and BTP of the posterior ribs to determine whether the KVP and MAS used is adequate or not. Meanwhile, for the thick structure, we are going to evaluate the visualization of BCO and BTP of the T12 of the vertebral body, also to determine whether the exposure factor used are adequate or not. This is the first example of an incorrect exposure factor used for this projection. The thin structure, which is the posterior ribs BCO, and also the thick structure, which is the T12 of the vertebral body's BCO, were both cannot be seen from the radiograph, indicating that the KVP used is over-penetrated. Apart from that, the BTP of the posterior ribs and also the BTP of the T12 of vertebral bodies were both cannot be seen, suggesting that the MAS used are overexposed. Moving on to the next example of incorrect exposure factors, the KVP and MAS used are both inadequate since the BCO and the BTP of the thick structure, which is the T12 of the vertebral bodies, cannot be seen in the radiograph. Besides, the BCO and the BTP of the thin structure, which is the posterior ribs, can be seen clearly. So, we are done with the criteria needed for positioning and exposure factors for lateral thoracic projection, and we are going to move on to the next part of this presentation video, which is the PACEMAN method to evaluate the lateral thoracic projection radiograph. Starting off with projection, this is a radiograph of lateral projection of thoracic. I say this is thoracic because the entire thoracic vertebrae from T1 until T12 or from the first thoracic until the 12th thoracic are seen through overlying lung and rib structure. And I say this is lateral projection because the intervertebral foramen are clearly demonstrated, the pedicles are in profile, and also the posterior surfaces of each vertebral body are superimposed to each other. Following the next P, which is the positioning for this projection is incorrect. This is because the posterior ribs demonstrate a space more than 1.25 cm or half inch, indicating that the patient's right thorax was rotated posteriorly. Therefore, to improve this, rotate the patient's right body anteriorly until the MCP or mid-coronal plane is perpendicular with the IR. Next is the alignment. There are three components for alignment, which are X-ray tube and IR or image receptor, and then the patient and image receptor, and the last one is X-ray tube and patient. For this radiograph, the alignment between X-ray tube and IR or image receptor cannot be determined because there are no four bodies of collimation present in the radiograph. Meanwhile, the alignment between patient and image receptor is incorrect because the distance between the border of the film and the central structure is unequal laterally. And the last one, the alignment between X-ray tube and patient cannot be determined because there are no four bodies of collimation present in the radiograph. The centering point for this radiograph cannot be determined because there are no four bodies of collimation, but the standard centering point for this projection is at 7 thoracic vertebrae or at T7. As for the collimation, at the superior border, the structure that should be included is 7 cervical vertebrae or C7. At the lateral borders, the structures that should be included are the anterior margin of all thoracic vertebrae and also the posterior column elements. And at the inferior border, the structure that should be included is the first lumbar or L1. Also, there is no evidence of radiation protection apparatus seen on the radiograph. Moving on to the exposure factor for this radiograph, the KVP used is adequate for penetration and radiographic contrast. This is because the BCO, or the bony cortical outline of the thin structure, which is the posterior ribs, can be seen, and the bony cortical outline of the thick structure, which is the T12 of the vertebral bodies, can be seen. The MAS used is adequate for detail and density. This is because the BDP, or the bony trabecular pattern of the thin structure, which is the posterior ribs, can be seen, and the body trabecular pattern of the thick structure, which is the T12 of the vertebral bodies, also can be seen. Therefore, the KVP and the MAS should be maintained for this radiograph. Next is marker. There is no evidence of an anatomical marker shown in the radiograph. However, there is an evidence of a post-processing marker shown in the radiograph, correctly placed on the left side of the body and placed appropriately, not superimposing any region of interest. As for the aesthetic, the film size used is 35 cm by 43 cm, which is sufficient to demonstrate all structures of interest, and also there is no evidence of artifacts seen on the radiograph. Last but not least, the patient's name and identification, date of examination, place of examination, and the radiographer's name are not visualized on the radiograph at the appropriate area. To conclude, the radiograph is unacceptable because of the positioning, because there is no evidence of an anatomical marker, and also because there is no visualizations of the patient's name or identification or patient information. It seems like we've come to an end. Before I end this presentation, I would like to say thank you for taking the time to watch this video. I truly appreciate the attention and also the effort you've given to reviewing my video. I'm genuinely feeling grateful, and although this is a recorded presentation, I still hope that it reflects the effort I've put in and meets the expectation. If there are any areas for improvement, I would be more than happy to learn and apply your feedback in the future. Once again, thank you very much for watching. Bye and Assalamualaikum.